Okay, now surgery. So we're going to discuss some of the indications for surgery.
We'll run through this. We're probably trying to cover too much, actually, I've realised. But anyway, let's,
it's a topic we're passionate about.
Yes. So discectomy, microdiscoid decompression, spinal canal stenosis, that generally there's a fairly high success rate, but there is a recurrence rate, particularly with discectomies and microdiscectomies. Absolute indication would be the cord-recliner syndrome, relative progressive neurological deficit, sciatica more than 6 weeks to 3 months, especially if it's a really big disc on MRI and it's unlikely to resolve. But there are risks associated with the operation, which can be nerve root damage, dural tear, bladder and bowel problems, bleeding, infection, of course, and fusion. Unpredictable results. I probably wouldn't be recommending fusion these days, but look, there are some good results from some levels. Single level fusion in a non-smoker, you'd get about 95% technical success rate at the bottom. That's the bottom level, L5S1, but only about a 70% clinical success rate. So it's not very good. Multi-level is even more unpredictable, and the indications. Well, it's mainly clinical, unable to function, discogenic pain, at least 9 months. And obviously a diagnosis based on history, examination, MRI findings, but obviously there's all sorts of other issues which crop up, including yellow flags.
So on the MRI, this is an example of, this is an important thing, modic type 1 change. So what we're able to see on the MRI is see that the disc is unhappy. We can see that there's a lot of disc desiccation. We can also see this bone marrow edema, so this sort of modic type 1 change. And that's probably more significant than if we say the annular fissures, which are more common. So this is sort of marrow edema of the end plate, breakdown of that end plate.
Disc replacement. You probably heard a bit about disc replacement. The idea is you're trying to maintain normal motion to prevent the knock-on, both up and down, from fusion surgery. But unfortunately, you're not actually getting normal motion because the facet joints are left as they are. So you're only actually replacing the disc with a disc replacement. And there's all sorts of problems associated with it. The results are not superior to fusion. There's an increased risk of facet joint degeneration at the same level. They have to be done from the anterior approach. And of course, you've got damage to large vessels, ureters. And in men, retrograde ejaculation is a reasonably common complication. And the implants can migrate, they can wear out, so it's still in its infancy. But there's lots of people trying to put them in, particularly in the neck. They do better in the neck, but then of course fusion does better in the neck as well. Nerve stimulators. This is a treatment for back pain and leg pain. It depends what you're trying to do, but you're trying to stimulate the dorsal root ganglia, and each dorsal root ganglia converges and diverges at about 4 levels. So you can use relatively few leads to cover quite a large area. You can put a lead in, 3 levels apart, and the object of the exercise is to convert the pain to paresthesia, and there are some very effective results, but it's quite expensive. It's about 45,000 for the nerve stimulators. There's various new age new nerve stimulators that are coming out now. And down the bottom, I think IDET and nucleoplasty and vertebroplasty is sort of largely out of favour, and intrathecal opiate pumps, likewise, there are all sorts of problems with those as well. TNF inhibitors, conflicting studies, and there are some favourable results, but it still hasn't come into fashion completely. So this is, trying to inhibit the tissue, the tumour necrosis factor, which is critical in the formation of a chemical radiculitis. There have been some favourable results, but some not so favourable. Stem cells, again, that's in its infancy. And next.
And the stem cells, there was a study began at Monash University, I think 4 or 5 years ago. Right at the neck, any results there?
I don't know. I don't know whether there's any anything positive at this stage with stem cells in any musculoskeletal conditions. Even putting stem cells direct from bone marrow into joints and so on. There's some reasonable results with PRP and autologous blood in tendons, but at this stage, stem cells haven't been shown to be superior to that. And next. Okay, so perhaps we just run through the summary. So I think it is our attempt to sort of try and distinguish between mechanical and non-mechanical pain, the features of disc problems and facet joint problems, whether you're going to see a physio or a chiropractor or an osteopath. Physios tend to sort of work more on discy issues with extension, but that's not always the case. And chiropractors and osteopaths tend to do more manipulative type treatments, which tends to work for facet joint problems more. Extension flexion exercises more for facet joint problems. So if and without any extension on examination, and extension exercises more for discy problems. And there are all sorts of traps, like physios prescribing extension exercises for canal stenosis because they've got sciatica. They think it's a disc problem, but it's a 60-year-old who's got canal stenosis or foraminal stenosis, and of course the patient gets worse with the extension exercises, and they lose faith in their physio, etc. And I would encourage you to refer to Andrew for targeted injections and pain chart for diagnosis, because he's very expert at it.
Yes. Anyway, we have a good relationship. Tim will often ring me up and I'll look at the scans for him on MRI Direct, and then he may send patients from his Cranbourne or Frankston practices up to Paran. It's a long way for them to go, but we tend to be very selective in how we're performing the procedure, and we've got quite a good team that all works together, and they report back to you, and we also provide this pain chart. And
if you do specific exercises, sometimes they may aggravate the patient and you don't realise it because they're warm. So it's like, I prefer getting rid of the inflammatory component first, whether that means rest or anti-inflammatories or avoidance of the aggravating activities, and then building up the core, and then I think they've got a better chance of the core actually being built up. It's a bit like trying to strengthen a knee and build up quads when they've got an effusion. You've got to get rid of the effusion, you've got to get rid of the problem before you can build up the quads. If you've got an effusion in the knee, the quads will waste. And so in my experience in musculoskeletal medicine, over 30 years or so, if you get rid of the inflammatory component first, you get rid of the cause, and then you build up you rehabilitate the muscles around it, then you generally get better results. But that's my experience.
So I'll just before we go to questions, I'll just give my final summary as well. That yes, there's different radiology modalities, and I think we'll let Patrick maybe chair it all. But there's different radiology modalities available. X-ray gives a good overview. Bone scan we use very rarely, just for staging or looking for working out where there's osteoblastic activity. MRI I would recommend rather than CT if the patient is able to afford it, because there's significant benefits in the no radiation and getting a lot more information, and it's just should be the way things are done. There's different disc lesions which we've described, past stress fractures we've got a particular interest in. It's cricket season. Also GPs can refer for MRIs of the lumbar spine in patients under the age of 16. I think some of you guys forget that. The patient if they're under the age of 16, there are different regions that GPs can refer. The patient needs to have an X-ray before. If they're over the age of 16, you're only limited to knee, brain and cervical spine. There's also a great website up there, mriforgps.com.au. I know we're all struggling for spare time, but if you've got any spare time, MRI for GPs is a great website which gives you some information. I'd also recommend that you try to get MIA Direct so that you can see the images and use those images to help educate and explain things to your patients. Also, it's a good way to get results. Mandy and all the girls can help you out with that. There are different procedures which can be done, and in the future I think MRI will continue, but I think we'll hand over. You want to quickly cover bursitis? Yep, we can cover bursitis. Yep.
Very, very common to get trochanteric bursitis and gluteal tendinopathy together. What is the thing that you're trying to treat? my view is that the history, they're often combined, but the most important part of the history is if it's more painful lying on that side at night, then it's probably a trochanteric bursitis. If they lie on the other side and it's not painful. If it's more painful, if the most obvious aggravating factor is walking upstairs, then it's probably a gluteal tendinopathy. And so, to be honest, that's probably the most obvious historical thing. But there's examination findings, and there's also radiological findings, and they're a bit different. The gluteal tendinopathy is most common in postmenopausal women. It's painful weight bearing, especially going upstairs, as I say. The gluteal tendons, they're known as the rotator cuff of the hip. They're responsible for abduction of the hip, internal rotation when the hip is flexed, and external rotation when the hip is extended. There are various ways of examining that. I don't think I'll go through all that now, but it depends on which part of the gluteal muscles, whether it's upper fibers or lower fibers, as to whether they abduct or adduct or internally rotate or externally rotate. As far as gluteal tendinopathy management is concerned, it's really physiotherapy and high-load exercises, retraining the gluteal tendons. There is some evidence that PRP and autologous blood injections are helpful. I personally find it more helpful in tennis elbow than I do in gluteal tendinopathies, but there are some that do well with autologous blood.